Everyone. My name's Roberta Ryan, and I'd like to welcome everyone here today to the seminar, The Future of Healthcare Financing by the Value in Health Economics and Policy Group here at the University of Newcastle, in the university's business school. I'd like to start with an acknowledgement of country on all our behalves. I'd like to acknowledge the traditional custodians of the various lands on which we're meeting here today. I pay my respects to elders past, present and emerging, and celebrate the diversity of Aboriginal peoples and their ongoing cultures and connections to the lands and waters of New South Wales. I'd like to particularly acknowledge the Gadigal people of the Eora Nation. That's where I am today, here in Sydney, this place we now call Sydney. There are 29 clan groups of the Sydney metropolitan area, collectively referred to as the Eora Nation. So it's a great pleasure for me to introduce the seminar today. I'm the Executive Director of the Institute for Regional Futures here at the University of Newcastle, one of the three flagship institutes here. My own work has been focused on the impact research and policy influencing research over the last 25 years, and I've got a particular interest in spatial inequality, a key factor of which is access to adequate and affordable health services and supports. The Institute for Regional Futures, we celebrated our first birthday last week. We were established in September 2002. We incorporate the long-standing Hunter Research Foundation Centre. All of the three institutes here at the University of Newcastle have emerged from the community. The Hunter Research Foundation Centre was founded in the mid-50s in response to the floods that affected the area back then. The Institute for Regional Futures is an independent fee-for-service research group. We focus on economic development, social science and spatial planning, and we work across the university's colleges with a focus on humanities and social science. We do all of our work in collaboration with our colleagues across the university. So it's a pleasure today to introduce this seminar, The Future of Healthcare Financing. Healthcare systems are in a crisis globally. Challenges such as ageing, chronicity, rising health costs of technology, affordable access to public health care, and the shortages in the workforce have been aggravated by the recent pandemic. Despite the adoption by governments of targeted interventions to address these critical issues, it's becoming increasingly evident that these challenges require some structural reforms. This seminar is part of a new series of seminars and webinars which aim to promote debate and discussion on contemporary work and research conducted locally and globally to inform health policy making and policy making more broadly. This seminar is organised by the Value in Health Economics and Policy Group in collaboration with CFAL Unitar, as well as the Institute for Regional Futures. The Value of Health Economics and Policy, or VheP, the VheP group as we call it, is an interdisciplinary, cross-faculty, multi-institutional and stakeholder-driven. This allows the group to effectively collaborate on research across a range of topics with the shared purpose of adding value to people's health and healthcare systems. As a diverse group, our output is related to improving health outcomes. It's a group of international network of researchers and consultants and practitioners and industry leaders focusing on issues related to decision-making, finance, policy-making in healthcare. In addition to the workshops and seminars, the group offers a suite of health economics, management and policy degrees. These are courses provided for students to provide them with a sound foundational knowledge of the current real-world circumstances and innovative information so they become the next leaders in health economics, management and policy and leave a lasting impact. Since February 2002, last year, the programs have been accredited by the Australasian College of Health Science Management, and since this year by the Royal Australasian College of Medical Administrators. I'd like now to introduce you to Francesco Paolucci, Professor of Health Economics and Policy in the Newcastle Business School at the University of Newcastle and the University of Bologna. He is the founder and leader of the Value in Health Economics and Policy Group. He is a scholar and advisor who over the last decade has published extensively in the areas of public policy, economics and management, with a strong focus on healthcare at the state, national and international levels. His work includes 3 edited special issues and peer-reviewed journals. It's my pleasure to hand you over now to Francesco, a great colleague of mine, to introduce our esteemed speakers and panelists.
Thank you, Roberta, for this introduction. First of all, thanks to the Institute for hosting us and in this very special day for New South Wales and also ACT. And I double thank all of you that are located in these 2 particular places, because you're dedicating your free time to, I think, a very important discussion and topic. I would like, first of all, to thank our 2 presenters today, Dr. Nathan Kettlewell. I hope I pronounced your name well. Certainly, I will do. I have done that better than the name of Manos, which will come right after, which I hope to represent well. So thank you, Nathan, for being here. Nathan is the recipient of a Chancellor Postdoctoral Fellowship at UTS. He's an applied macroeconomist who has worked on a variety of topics very relevant in health economics that range from private insurance to preference elicitation and mental well-being. He has been awarded in 2022 the Rising Star Award by the Australian Health Economics Society, recognizing him as a person whose work is beginning to make a significant impact nationally and internationally, reflecting either scientific excellence or policy impact. So thanks for being here, and we look forward to your presentation, Nathan. Professor Menzaki is a colleague that has worked with myself and others, including Andrew Matthews, in the works related to the evaluation of the private health insurance regulatory framework in collaboration and under the leadership of Finity Australia. And we'll also present today is the head of economics in City University of London. He has an extensive knowledge that ranges from health and applied economics and experimental methodology and experimental economics more broadly. His work mainly focuses on applications to health and also environmental issues, and as well as application range from private insurance to preference elicitations on a wide variety of topical issues. Now to the distinguished panel. So I'm really pleased to have here with me on my right-hand side. For you is probably also it's actually the left side of the screen. Professor Florian Büchner, who's visiting all the way from Germany and Austria, where he's currently based, also, Florian and I have worked for a number of years. Florian is an expert in insurance and payment models. In particular, is one of the members, and I think even one of the founding members of the Risk Adjustment Network, which is a network of researchers that really look at insurance issues, and in particular on how reimbursement and payment models are designed globally. Florian is currently visiting the University of Melbourne. Thank you, Florian, for making your way up to Newcastle in person. Now, staying in Melbourne, I would like to introduce you to Yuting Zhang. Professor Zhang is at the Melbourne Institute of Applied Economics and Social Research, She obtained her PhD from Harvard University. She has a very extensive experience and definitely an incredible curriculum and success in funding and Category 1 funding grants awards from the ERC to the NHMRC, but also overseas. Again, looking at the variety of health policy and economics issues. She has published extensively in top journals, and particularly on this topic, together with Nathan, has contributed to lift the debate around really what to do in terms of the policy reforms discussions surrounding private insurance in Australia. It is my great honor and really privilege to have Professor Stephen Robson here, who's dedicated his very busy schedule to you and us. As you all know, he's the president of the Federal Australian Medical Association. I've heard he's also actually undertaken studies in economics, so he has an incredible background that is not only unique but important, as the combination of these two, let's say, areas and disciplines is quite important to understand the complexity of this, fast-growing and changing industry. He has a very extensive experience and career. He has 2 PhD and he has been really involved in the Australian context, but also in the British and American context. So thank you very much, Stephen, for being here with us today. As a coincidence, there is no relation between the two. Professor Alex Robson, who's a member and in fact is the deputy chair of the Productivity Commission, and he has a very long-standing relationship with myself, as we have co-authored a number of papers when we met in Canberra a long time ago. Since then, he has taken a stellar pathway and career in the public service, of course, here in the Australian context, but also more recently serving as our ambassador in the OECD. So he's connecting from Brisbane, if I'm not mistaken. Thank you, Alex, for being here with us today. And then I think I have 2 more to go. It's a very rich panel. I'm very excited about having you all here. I would like to welcome Rosalie Winey, who's a professor of health economics and the director of one of the most prominent centers of health economics globally, and certainly in Australia. SHARE has been in fact the center that hosted the International Health Economics Association conference a few years ago. She has an extensive experience and knowledge in health economics in a wide variety of topics. She has been part of a number of important committees contributing to academia and society nationally and internationally. I'm very thankful for Rosalie to be here with us today. Last but not least, Andrew Matthews, who is, I'm not sure in what hat he's going to wear today, probably both hats, but is a part of Finity, which had a very important and pivotal role in the whole exercise conducted by government in understanding and evaluating the current private insurance arrangements. And he's also a professor at Monash University and has taken in the past a very important leadership role in the private insurance industry as chief actuary of Medibank Private and other important board roles. Thank you all very much for being here. I see you're all being very diligent in keeping your microphone off for the moment. The way in which we will conduct this meeting, for those who are listening to us and seeing us today, it goes pretty much as follows. Nathan will talk for about 15 minutes, give or take. Manos will follow without interruptions apart from myself. And then if you really have an urgent question, I will ask you to write me in the chat UQ, and I will give it immediate attention, and I will determine whether it is really urgent. And it's always a subjective evaluation, or whether it can wait for a little bit. If you just have a question, please do use the same, just put a Q in front, and then I will give it less priority. If you have a long question, use my email, because then I can operate on another device and be multitasking while listening to the presentations. That is it. So Nathan, again, welcome. Thanks for being here. You can unmute yourself, share the screen and your presentation.
Thank you, Francesco. So hopefully that's all fine. All right, I trust somebody will jump in if this isn't streaming. So thank you very much for the opportunity to talk about this research today. So this is a recent paper joint with Yuting, who's in the panel, looking at financial incentives and the demand for private health insurance in Australia. So yeah, with this group, I probably don't need to spend much time on background. So Australia obviously has a system of universal public health insurance, which is Medicare, which does fairly well at providing hospital care for free, and a lot of other healthcare as well to the general public, and that's funded through general revenue. One thing that surprises, I think, a lot of people from outside of Australia is that in addition to this universal public insurance, about half the population also holds private health insurance. And this private health insurance isn't particularly cheap, so people can spend around $160 per month, or around 2% of median earnings on insurance. And if you buy more generous policies, it can be a much greater fraction of income than that as well. So I get asked this question a lot when I present internationally, like, why do people buy private health insurance at such a high rate in Australia? So the first kind of natural reason is that there's some quality gap between public and private care, and what I mean by quality gap is is quite a general thing. So that includes the fact that if you can go to a private hospital, obviously you can access treatment more quickly. So it's that ability to jump the queue. There can also be other perceived or real quality differences that drive demand. So that's one thing. The other thing is the system of carrots and sticks that have existed for the last couple of decades. So there's a tax penalty for high income earners, there's an age-based penalty, lifetime health cover, and there's a premium rebate. And together those three policies seem to prop up demand. And so that's what our paper is kind of interested in. So we want to look at the effect of basically two aspects of this kind of carrot stick infrastructure, which is the Medicare levy surcharge. So this is the tax penalty for high income earners who don't buy private health insurance, and the simultaneous withdrawal of premium subsidies. So basically the means testing of the private health insurance rebate. So what the kind of policy context looks like in a nutshell is this. So if you're a single person earning less than $90,000 and you don't have private health insurance, you don't have to worry about the Medicare levy surcharge. Okay, so there's no penalty for being uninsured. And you also have a significant part of your premium subsidized through the private health insurance rebate. So these rates are a little bit different to today. I think this is from 2018, because that's the year that our data are from. But essentially you can get a rebate of around sort of 25% if you're under 65, and then higher rates if you're over 65 or over 70. The thresholds are doubled if you're in a family, meaning you're a couple or you're a single parent, or you're a couple with kids. So if your income goes just above that 90,000 threshold and you don't have insurance, that's where the MLS penalty kicks in. So this is a pretty big stick. So that would be 1% of your taxable income as additional tax that you would have to pay. So if you're uninsured, you essentially would have to pay an extra $900 a year in tax, or buy insurance. At the same time, the rebate reduces as this kicks in. So you've got these two sort of somewhat offsetting effects: this increase in the tax penalty, but also a reduction in the rebate. What's kind of interesting and something that maybe previous research on this policy hasn't focused on so much is that the incentive effects are perhaps very different on the take-up and on the generosity of coverage margins, so extensive and intensive margins of insurance. So clearly, like, this 1% penalty creates a very big incentive to buy insurance. In fact, when we looked at what we think premiums were in 2017-18, so the year of our data, it seems like in New South Wales, you could have always found a policy that was cheaper than the penalty, regardless of your income. So in that sense, it's financially irrational not to buy insurance. However, notice that the rebate is a fixed percentage of the premium. And so the fact that the rebate reduces could encourage some people to downgrade their cover, to switch basically the cheaper cover because they don't get as much back. And so that's something that we're able to explore with our data, because we have information from insurers, not just on whether people are insured, but also on how much they spend on the insurance that they have. So just to complete this table, you can see that there are two other tiers as well. So tier 2, the MLS goes up a little bit more, the rebate comes down again. And then at tier 3, there's no rebate, and again, the MLS goes up a little bit. And so we're going to be interested in behavior at all of these different tiers. So just to reiterate one of the points I made, so here this green line is the after rebate premium for a single person using kind of like an entry-level policy in the year 2018. So you can see that that premium goes up at each of these tiers as the means testing of the rebate kicks in. However, this red line is the MLS. And so if this red line is above the green line, that tells you that you could save money by buying insurance rather than paying the MLS. And the gap between these two lines is like how much worse off you are by paying the MLS rather than just buying this cheap policy. And so we can see, right where the policy kicks in, it's still probably better to insure, but it's quite close. At these higher tiers, tier 2, tier 3, if you're not buying insurance at that point, you're probably very, very resistant to this policy. And so, that kind of drives our predictions a little bit, which is that at these higher tiers, we might see more of this downgrading behavior. So we might see more of this, intensive margin response, but we probably won't see much happening to take up. Right. So to kind of answer this empirically, we use data from the Australian Taxation Office. It's called ALIFE. This is a 10% random sample of tax filers. It's a very good data set. It's a panel, but we only use data from 2017-18. And there's one of the main reasons for that is that those policy thresholds had been stable for 4 years over that time. So that had given people time to kind of adjust to where they were, and also predictability in what the policy would be at the end of the financial year. So we think that's kind of a good year to use. It's also the last year available. It's the most recent year available in the data set. We have a sample of 1.2 million people. Our models don't use that full sample, so I'll explain how we estimate effects in a moment. So of that 1.2 million people, about 1 in 5 have income that's above the MLS. So that gives you a sense of how many people this policy affects. But what I'll also show you is that the policy is probably binding for a very small fraction of that 1 in 5. All right, so to estimate the effects of the MLS, we're going to be using regression discontinuity design. So this is a pretty intuitively simple estimation technique. The idea is going to be to exploit these sharp changes in the policy settings that happen at the thresholds, so where the MLS kicks in and the rebate withdraws, and basically compare people with incomes just above and just below. The idea being that those two groups are basically comparable to each other, but they face these different incentives. And so that'll give us an estimate of the effect of those incentives on behavior. So pretty much we can, summarize the whole paper in this graph. Of course, we need to do a lot more sophisticated work to get published in academic journals, but this is kind of it. So here, if we look at the top row, this is showing the relationship between income and take-up of insurance for couples and families and for singles. And so what we can see is it's this very strong income take-up gradient. And then what we might expect is, a big jump in take-up at the MLS threshold if the policy is effective, because that penalty is obviously quite steep. We do see a bit of a jump here at the tier 1 threshold, but we don't see much happening at tier 2 and tier 3. And that to me is intuitive because, as I showed you before, at these thresholds, if you're not buying insurance already, maybe you just don't know about this policy or there's something else going on, you must be very resistant because you're making a very bad financial decision. The other thing that I think is really noteworthy here is that, particularly if we look at couples, families, right, at the threshold, the probability of buying insurance is already about 90%. And so what that tells you is that, even if the MLS is quite effective, it's affecting it's affecting about 20% of tax filers. And then within that 20%, it's something less than 10% who actually are unlikely to have insurance anyway. Right. So basically what I'm saying is that this policy is only likely to be binding for a relatively small fraction of the population, if we believe that this kind of trend in income and take up of insurance would kind of exist regardless of the MLS. If we look at the graph for singles, it's quite similar. There's a bit of a jump here at tier 1, not much clearly happening at the other tiers. And then in this bottom row, we have the same sort of graphs, but we have premiums. So this is how much people spend on insurance. And they basically mimic what we see above here, which is a bit of a surprise. So we have this jump in premium spending, which just reflects the increase in the number of people. Though even if we condition on having insurance, there's still a jump in premium spending. And so that suggests that people who are on the margin, so these people who are induced into insurance, they're not buying cheap insurance. They're buying insurance that's not cheaper than the average that you would expect at that level of income, basically. And so this kind of goes against the junk policy narrative. It's not to say that there aren't people doing that, but it's just not super pervasive, apparently. And then for singles, yeah, it's the same thing. And the other the final point is just that at these tier 2 and tier 3 thresholds, we don't see any response on the premiums margin. So even though the rebate is coming down quite substantially, there's no change in how much people are spending in insurance. And so that suggests that people are quite, that this means testing of the rebate isn't causing people to sort of downgrade their cover or buy lower quality cover than they would otherwise, which was a big concern raised by insurers when this policy was introduced in 2012-13. Right, so in order to formally estimate all of these things, what we do in a regression discontinuity design is basically we fit a curve on the left of this threshold and on the right. And so we predict what insurance take-up would be on the left, and on the right, we take a difference in those predictions, and that's our RDD estimate. So it's a little bit more complicated than that in this case. So we have to account for the fact that there's some income manipulation. So we do some stuff to identify basically the income range where we think people are sort of manipulating their income to avoid the MLS. And we do find strong evidence of such behavior, particularly around tier 1 thresholds. So we deal with that, and then we have to run some model selection algorithms to basically pick how much data to use on the left and the right, and whether to use a linear or quadratic fit. What I'm just going to show you today is kind of a bunch of regression results that varies like all of those different decision parameters that you could make. And so you can see what results are kind of robust and what results are not. I just saw a question in the chat, so I can answer that. It's a quick one. This period is 2017-18. So this is a 2017-18 tax year, which is the most recent year that we have this data for. All right, so here are the results. So this is looking at take up in the top row and premium spending in the bottom row. And the way to read this graph is, so if we look at the red line, this is a linear fit on the left and on the right of the threshold. So it's a linear RDD without control variables. And as we move from the left here to the right, we're increasing the bandwidth. So basically the income groups that we're using. And that's kind of a trade-off between bias and variance. Like a longer bandwidth reduces variance, so you get kind of tighter confidence intervals, but you get greater bias because the curve fitting might not be as good. And so what we can see is that across all of these different bandwidths, $5,000 up to $25,000, we get a positive and significant effect. And that's in the range of between 4 percentage points to 1 percentage point. And then if we use a quadratic fit, we add controls, we do quadratic with controls, we still get estimates that are statistically significant and within that kind of similar range. For singles, we get estimates closer to sort of 4% that are a lot less sensitive to the length of the bandwidth. Again, so that seems to be a true effect. And then for premiums, we get sort of similar results. And I just point out that the relative jump in premiums is greater than the relative jump in take-up. So again, that's suggesting that the marginal joiners are not buying sort of cheaper insurance than the average person at that level of income. So those are results for the tier 1 threshold. At tier 2, we don't get anything that's kind of robustly significant. So you can see 0 here is well contained within the confidence interval in all of these different graphs. So I don't need to spend too much time on this. So we just don't see much. And then at tier 3 threshold, it's the same thing. So clearly insignificant results that are close to 0 at both the take-up and the spending margins for both couples and singles. Okay, so then what do we kind of conclude from this? So, I mean, according to our estimates, the MLS seems to explain a fairly small fraction of demand near the policy thresholds. So that's obviously the only effect that we can pick up. There could be more complicated dynamic effects that we're not able to pick up with our model, but the kind of beauty of the RDD setup is that it's a very clean way of estimating causal effects. We also don't find any evidence that the withdrawal of premium subsidies leads to downgrading. And so that implies that the price elasticity of demand at the extensive margin must be very close to 0 or even 0 for these really high income earners. And so that suggests, that further reducing the premium rebate for this group isn't likely to lead to mass downgrading and could potentially be a good financial, good way to, I guess, like reduce fiscal outlays. We also haven't sort of discussed this in as much detail because of the length of the talk, but we also find very strong evidence that the MLS leads to income manipulation. And so that should also be considered as a cost of the policy. So it's not a cost that we quantify, but, for example, if we had like a single tier threshold, obviously there's more to that, cost benefit analysis than just this, but a single tier threshold would reduce the range of incomes in which there is manipulation. Anyway, so that's it. Thank you.
Thank you, Nathan. If you can, for the moment, stop sharing so that Manos can start sharing.
Sure.
Beautiful. Thank you so much, Manos.
Yes. How do I share? Let me see. Oh, share. Can you see this? Can you see my sharing?
Yes,
Yep.
yes.
Yep.
All right, cool. Uh, thank you for having me, first of all. And amazing to follow Nate's presentation. Uh, so f- we so we are doing something a little bit different with respect to the methodology mostly. So just to say that this is again joint work with Michael McLean and Francesco Paolucci. And we don't have a draft paper yet, but it should be coming soon. So I guess most of the contextual and regulatory context has been provided by, in the previous presentation, so I'll just skip that. So essentially, the main question or the driving questions for this study was around how do consumers respond to changes in the different types of regulatory tools and whether there is a difference in terms of uptake or product choice, and then whether we can identify some heterogeneity in those effects with respect to, again, uptake or product choice. Overall, differently from the previous presentation, this is a sort of experimental survey which we utilize to respond to this. And we focus, as I said before, on rebate, MLS, LHC, and base premium. We also focus on so this is our main interest. We also focus on a couple of other aspects of the system, but we'll come back to that later. So essentially, this study or this survey it was sort of incentivized by the need to know how changes or deviations from the current status quo would affect the market. And some of them, for example, reducing waiting times or changing the quality of the public health system are a little bit more difficult to implement. But anyway, they're here to be tested, let's say. Some quick preview of the results. So given the parameters of our experiment and the specific kind of deviations, if you like, of the current status quo that we examine, what we find, MLS and rebate rates have strong effects on choice and product, on uptake and product choice, particularly from removal of MLS or rebate, particularly rather than changing the rates. Change in base premiums, rates, and LHC rate and thresholds do not necessarily have statistically significant effects either on uptake or product choice. And then finally, we find that general other characteristics, again, those we examined, seem to have limited effect on our results. So the type of changes or the type of effects that we are sort of examining is changes in the LHC rate. So you can see we have a status quo, and then we have a decrease or increase up or down, and then we also have LHC threshold. So this is again the kind of the age cutoff through above and below which the LHC applies. MLS rate, again, status quo up and down. Again, the threshold. So this is something that was presented also before with respect to the cutoffs. And then there is an exemption. So there is a little bit some discussion. So at the moment, MLS exemption, you get MLS exemption if you have any type of coverage. What would happen if you needed a specific type of coverage and above? So basic coverage wouldn't exempt you, for example. Then we also look at rebate, again, status quo, increase, decrease, or removed completely. Then we're looking at out-of-pocket expenditure. So essentially how much you contribute, let's say, to your treatment. So guarantee zero, maximum 500 per treating doctor, or variable depending on treating doctor, which is again the status quo. Then we're looking at the public system, the quality, and with respect to waiting times. And then the last ones are the premium up compared to the status quo, up or down 10%. So one thing to say in these premiums is that for technical reasons, or to, let's say, reduce the cognitive burden, if you like, or the sort of yeah, anyway, so to reduce the number of situations that we need to examine, or the scenarios, we're grouping premiums. So essentially, basic and bronze move together parallelly upwards or parallelly downwards. Same with silver and gold. So essentially, for each of these groups, we are able to estimate or to identify a separate effect, but not we cannot distinguish between basic and bronze or silver and gold. So this is an example of how it would look like for a participant. So we have the status quo scenario. So if you choose, sorry, going back, if you choose the status quo on every one of these attributes, you sort of create the current market that is present. I should say that some of these attributes or some of these values are individual specific, and this is accommodated. So according to so as soon as someone participant comes into the experiment, to the survey, we elicit certain individual characteristics, and then the table is presented for them specifically. So it's personalized to individuals, but people see, or respondents see, the base premium, then the rebate amount, how it translates, let's see loading, and then at the bottom they see how much they would pay per year, sorry, if they were not to purchase at all. And then, as I said before, they can choose one of the four cover levels or none. So sorry, this is the status quo. So you can see, for example, this is where a rebate is increased. So there is a change, there is a drop in the rebate. So everything is recalculated based on this change in the market, or this hypothetical change in the market. So experimental design is, so this is a between subject design. So we have 38 plus a status quo, so 39 sort of market scenarios. So each of them differs to the status quo either by one levels or one change, or two at maximum. So we allowed for some interactions between MLS and rebate and base premiums. I don't explore them very much in this presentation because they didn't seem to matter that much in the end. As I said, we're grouping the premium changes, and so the last thing to say is that even though individuals potentially see or focus on the final value of the premium that they're paying, the changes, the background changes in the various tools allow us to identify separate effects for each one of them. With respect to data collection, so this is through an online marketing panel. Each respondent saw 10 out of these 39, randomly 10 out of these 39 possible markets. We have about 1,500 respondents. As again, everybody making 10 choices. So a relatively small or moderate sample. We have representation from all states, and we seem to cover, male, females, almost balanced. And then there is a mean income of about $60,000. Now, with the statistical analysis, nothing particularly complicated. So it's just first, it's a simple binary choice, whether you buy or not. So basically, we group any purchase decision as yes versus no. And then we're looking at how the different changes in the market affect the probability of saying yes. And then categorical choice, so basically what type of product you choose or whether you opt out. So this is, again, modeled through a multinomial logic. And again, we calculate the probability of each of the 5 options given the characteristics of the markets. Yeah, okay. So with respect to the results, quickly, so the first one looks at the probability of choice when there is a change in the rebate, the MLS rate, and the MLS threshold. So you can see that changes in rebate rates and MLS threshold do not affect the probability to uptake health insurance. We see that an increase in the MLS rate by 1% increases PH uptake by about 11.5 percentage points. Then looking at the removal, so how does the probability affect, so how does the removal of MLS or rebate affect the probability of purchasing health insurance? So MLS removal drops by about 2.2 percentage points, marginally significant, and then the rebate removal drops again by about 4.2 percentage points. That's statistically significant. Then moving on to product choice. So I'm trying to highlight a couple of significant findings. So increasing rebate by 1% decreases the choice of basic by 0.15 percentage points, and the gold by 0.15 percentage increase by 0.15 percentage points. And then again, removal, we can see that removing rebate increases by 3 percentage points, and then decreases bronze, silver, and gold by 3, 2, and 2.4 percentage points correspondingly. Removing rebate increases opt-out by about 4.2. And then finally, when looking at the MLS rate, again, increasing 1%, we see, again, some statistically significant changes to the product choice. MLS removal, again, some significant effects mirroring the results from participation, albeit less widely present across the different product types. Okay, so then we also have, so then looking at the subgroups, so how do marginal effects differ by income, age, and household type? So what we find is that rebate removal is concentrated, the effect from rebate removal is concentrated to those below 90,000. MLS rates effects concentrated on those above 90,000. And again, MLS removal concentrates on those who are wealthier. With respect to age, rebate rate significant for those higher or over the age of 65, 64 or 65 plus. And then MLS rates, again, 45 plus. For household status, rebate removal concentrated on those who are non-single, so family. I guess there is many types of not being single, so it's just a residual category, if you like. How do probabilities of the 5 options change when MLS exemption requires at least silver? So again, compared to the standard status quo scenario, requiring a minimum of silver to qualify for the MLS exemption decreases the probability of basic by about 6.6 percentage points and increases silver by about 7 percentage points. So again, according to expectation or theory, or what would theory suggest? Base premiums, how do changes in base premium affect the probability of purchasing decisions? So you see here, so on the far left is the status quo, then we have a bronze basic decrease, bronze basic increase, so basically the different scenarios, if you like, in a categorical nature. So what we find, so mean and confidence, 95% confidence interval. So you see that the confidence intervals overlap, suggesting not much change. And we do find some differences here, but again, over time, over the various scenarios, the confidence intervals overlap. So again, we would suggest that the effect of base premium on choice of product is not strong and is not statistically significant. Okay, so again, this is now numerically, I mean, we can probably skip in the interest of time. The only thing to say is that probabilities of participation, of uptaking or of opting out, not statistically significantly affected by a change in premiums. And again, we find little heterogeneity in this effect. We do find some statistically significant effects for the let's say, the product choice, but again, not necessarily strong. How do the premiums again change by individual characteristics? So if we find that the effects of silver and gold premiums are concentrated on those on lower incomes, and then again for higher age, concentrated on non-single households when we look at status, at family status. The probability of opting out not affected in general by changes in premium. So this is with respect to LHC. Again, you can see that across, so this is status quo, removal, change in the threshold, and the two together. So this is the interaction. So again, we see that there is an overlap of confidence intervals, so little effect on the probability for uptake. And then again, when we look at type or product type, you can see that across a single color, across a single shape, there is little variation across the different treatments. So not much effect from changes in the market or in the hypothetical features of the market or in the features of the hypothetical market. Again, this is a numerical representation of what I was just saying before. One thing that we find that is interesting is that for those aged 30 to 45, an increase in LHC by 1 percentage point, so essentially from 2 to 3%, increased probability of basic coverage by 5, almost 6 percentage points. Other than that, we find relatively little heterogeneity. Moving to features that are a little bit wider than the regulatory tools, we find, so this is essentially how do out-of-pocket expenditure and public hospital wait times affect. So this is participation. So we find, so status quo, no out-of-pocket expenditure, max 500. And then we have the public system is worse, the public system is better. We find no effect. There is some. So a worse public healthcare system increases silver by quite a bit for those wealthier. Again, a public system reduces basic for those who are less wealthy. So overall, we find that changes in MLS rate and MLS removal have significant and sizable effects on PHI uptake and product choice. LHC rates or threshold little effect. Changes in rebate rate do not affect uptake, but removal does. Removal of rebate does have significant sizable effects. Base premiums have work in the same direction as expected by theory, but have little small significant, let's say, and other market characteristics are not particularly they're not particularly with a strong impact. So as a second step, and if I still have time, we perform a simulation exercise. So essentially what we wanted to examine is that whether people would perceive the same total cost change or the same total premium change when it comes from different sources. So for example, does a net price increase of 10% result in different participation in product choice if it is caused by a change in the base premium or by a change in the rebate? So essentially we can create a total cost function for whatever everybody pays for their policy. I mean, the specific characteristics don't really matter that much, but so these are the simulations with tests. So let me just go, sorry, I apologize for the small font. So for this first and second simulation, so we're looking at basically whether changes of plus minus 10%. So simulation 1 is plus, simulation 2 is minus 10% in the net premium caused by a change in the base premium versus a change in the rebate changes things. So in general, we find that reaction to the base premium are stronger than the rebate, but not statistically different. So I would say not very much. For product choice, we find some effect on the gold product, but this is not sort of generalized. For simulation 3, again, we're looking at whether removing the rebate entirely versus an equivalent change in the net premium caused by a change in the base premium are perceived differently. And here we find that there is a much larger drop on participation, about 7.3 percentage points, from removing the rebate than would be suggested from an equivalent change through the base premiums. Then we're moving to simulation 4 and 5. So again, plus minus 10% from base rate or from LHC. we find the impact on participation is larger for changes from LHC rate than equivalent changes in the base premium or the rebate. But again, not statistically significant differences. Again, we find for product choice that increase due to LHC rate drops gold product choice. We don't observe this from changes in the base premium on the rebate. And then the last one looks at the effect, the comparison between MLS and net premium, and we find no statistical significance. Again, this is maybe different to what we were observing before in the kind of estimation results, but what's important to know is that the MLS change here considered is quite small, so it's 0.1%. So it's not potentially salient. Just quickly to cover a few limitations for a study. So this is of hypothetical nature, right? So this is essentially if you are a potential hypothetical bias is present, although the experiment is not necessarily intended to capture the absolute level or the absolute choices, but the relative differences between the status quo and the other markets explored. Then we do find internal validity, so we move along the similar lines with theory and expectation. Generalizability is potentially an issue, so we tend to have a wide distribution and cover all the whole distribution of age, income, and household status. But of course, with 1,500 individuals, we could consider this as a preliminary or pilot study. We don't have any power issues, so any testing or any comparison between status quo and a different market is sufficiently powered with respect to sample size, but yeah, generalizability is a quite slightly different issue. We do explore the given scenarios that we have, but we could expand and explore other types of questions that may be interested. So a lot of this, what we do was guided by external, like the Department of Health and so on. And then finally, this is a demand side experiment. So of course, we assume that the supply remains the same. So there is nothing from the insurance industry changes, which most likely would happen. But yeah, so this is it. Thank you very much. Let me stop sharing.
Thank you, Miles. Thank you, Nathan. Wonderful presentations, very interesting work indeed. I would like now to start our panel discussion by inviting Florian to give his impressions and comments. Yeah, please.
Okay, Francesco, thanks a lot for inviting me, and thanks a lot to everybody in the panel to have me as a participant here. It's always interesting and challenging at the same time to have a look in a foreign healthcare system and in a foreign health financing system. Interesting because you may learn even something about your own system by seeing that it's possible to do it in another way, because everybody is used that it works more or less like in the healthcare system or health financing system he is grown up with. It's challenging at the same time because it's not so easy to get in these special regulations of these systems. And so there are, of course, quite some questions coming up seeing these regulations. Having seen these two presentations, I was quite impressed. I think both are very interesting. They are methodologically very different. They come from different perspectives. They use different data, looking more or less on the same topic. So at the end, I think it's a great thing for policymakers, for decision makers, to have this as a base for further considerations and for making decisions. So I think that's really a great situation. Also for both of the teams having done these studies by comparing the results and looking what brings the other perspective to my study. Coming to Nathan, I was very impressed. It's very interesting. For me, coming from a other health insurance system and having worked for an insurance company, so really having been in this context, seeing one of your very simple diagrams at the beginning, where you see the Medicare levy surcharge and the cost of the private health insurance premium. I thought, oh, that's clear. Everybody with a income over 90,000 Australian dollar per year, or 180 in the family. Everybody will buy the insurance, even if it's not of use for him. But that's not the case. So I was very surprised about the small jump at this, especially in the first threshold. You had a jump, and there has to be, you mentioned that, there has to be some explanation, especially for the individuals, to have 1/3 of them not having health insurance, even if it makes completely sense from a financial point of view. Do you have any explanation of that? And is there any approach of making some additional research on this topic? Because I think that would be very interesting. And I may come to the second presentation. I was about Manos. Thanks a lot. It was very interesting. And you said at summarizing your results at the beginning that the lifetime health cover is this additional payment they have to do. It has no influence on the decision of taking up private health insurance. At the end, you said it's only little but not significant impact. My question is, and you already had a remark in the presentation, if you split the group in a group of people aged up till 40 and a group 40 and older, I would expect you get significant results in an opposite direction. So the younger ones will, having this abolished, they will increase their take up of insurance, and the older ones and they will not increase it, or the other way around. So I think you will have significant results for these two things. And as a last question, coming from a foreign country, and looking at these three, at the system of these three tools, I ask myself, what's the target, the objective of doing this? Is it to increase the participation in private health insurance? Is it the maximization of utilization of private health insurance? Is it that you want to minimize public expenditure in the hospital sector? Or is it to maximize social welfare? And if it sounds like it's the same, but it's only very similar, and if you distinguish the objectives, you have to think about these tools in a different way. And that would be very interesting to know what's the target, the objective of these three tools in your system.
Beautiful. Okay, so I'll step in. I'm sorry, as the chair, I'm going to use Florian's comment to go to the panel first. I would ask the first question, which was really on Nathan and Yuting paper. What's Yuting take on that question? And if you can please unmute. Yeah, great.
Can you remind me the first question? A lot of questions.
Sorry. It was the question was a Homo economicus, purely financial person, would surely go for buying a basic private health insurance in case of having income above 90,000 Australian dollars. And we only see a very small jump. We see a jump in the probability of having private health insurance, but there is almost 1/3 left of the population. What's the reason for that? And is there any idea of you to make a research on this question? Because I think if you want to increase that, you have to get there.
Good.
So I assume you talk about among the singles because the family is over 90% of them already have private health insurance. So the singles above that first income threshold, about 70%, right? Is that the number?
Yeah, correct.
Yeah. My guess is some of the I don't think that entire 30% of them they actually lose money in terms of not buying it. I'm guessing some of the regions maybe they just don't have very cheap enough plans to offer if you compare that. So that's one reason. And some other reasons, for example, just some people might prefer to support the public system. And some people, it may be just their income changes, they're not aware. So if you talk about that, the first threshold, that's the people, sometimes they reach it. And maybe a lot of them, the first time they reach this threshold, they haven't really thought it through. So I think that's probably primary result we find for that first threshold and for single consistent with that. I think Nathan looked into data, maybe 13% of those people, 15% of those people who are above the eligibility threshold, and they actually pay the Medicare levy surcharge instead of buying a plan. So that's probably the population we're really talking about, not the whole 30%. And I think for reasons I just mentioned, we don't really know exactly the reasons. That's something we're going to look into.
Yes.
Okay.
Yeah.
That's good.
I
want to. I'll come to Steve and Alex. Okay, I love hands. So I'll follow with a bit of a cue on what you think, Sam, related to Florence. So you answered with this concept of supporting the public system, right, or the public sector. That is why they may not purchase it. But the whole idea of purchasing it might be a way to support it, right? If it offsets public spending enough, right? So that is one of these things that we're trying to work our ways through. So what's the best way, right? So I forget about private insurance. I directly believe that the taxation system is going to do the best for my money. No, I think actually the private system is going to be more efficient with my care. And then, for example, to make it very simple and colloquial, I free up a bed in the public sector, lower waiting times, and so on. So on that, I would like to get Steve perspective, and then, of course, you can add whatever you want.
Yeah, look, thanks very much. I speak as a medical procedural specialist who works in public hospitals and private hospitals. And I see all the time people say, I didn't take out cover because I just didn't think I'd need it. I wouldn't get it. If you look at uptake in the first place, the two big drivers are having a baby. So that generally occurs for couples in that sort of late 30s, early to mid 30 age group. Or if you look at the big things in a gold policy, for example, they're having your cataracts done or a hip or a knee replacement. So you have a group of older people who want these big procedures. And unless you're going to have a baby, there's some mental health driving uptake. But a lot of people just don't think they need it. And suddenly they find they've got bowel cancer or something like that. And I hear all the time in public patients that I see, oh, God, I didn't think I'd need it. I really wish I'd taken it out because I'm now on a waiting list that's going to take ages to get this done. And people want to know, can I just pay out of pocket to have it done and things like that. So I think a lot of the drivers are around a sense of risk. What is my risk of something happening? For a young couple, we know that 80% of young women will have a baby. So that's one of the drivers that takes it, but often single young men in particular, which are 50% of single younger people. I just don't think anything's going to happen to them if they end up with a unexpected condition that does require surgery. So most of the stuff, unless you're getting glasses and things like that, which you probably pay anyway, is about surgery. And a lot of people just never think they'll need surgery.
Then if your income is above 90,000 and you are one of those single young men, you're gonna actually potentially lose money. So basically private insurance still gives you something. So that question remains, like in that 30%, I think it's a very interesting question, and I'm happy to hear that you think and Nathan are thinking about it. And I go to Alex with his hand up, and then Rosalie for her impressions.
Yeah, thanks, Francesco. A couple of really good papers, I thought. I just want to make a couple of points. I mean, on the general question that Florian raised at the beginning, I mean, and Stephen sort of hit upon it, is that if your valuation or willingness to pay minus the subsidised price is still less than the tax penalty, then you won't take it out. So it all depends on, exactly as Stephen said, these life events and whether that, how that affects your perceived valuation of this good that you're buying and risk adjusted and everything else. So that's going to vary among, as Stephen said, demographics and individuals. I thought Florence, questions that you posed is exactly spot on. Like, what are the objectives of this suite of policies? And the ones that you outlined are exactly the right ones. And but if you could get different answers, you would get different answers, I expect, depending on what objective it is that you're trying to solve for. So, and that's always been a bit of a problem in this area. We have, the objective of this suite of policies is not exactly clear from a public policy point of view. Well, at least to me, it's never been totally clear. The objectives sort of switch around. I just had one question. I mean, it was striking to me, so Francesco, you and I have done a bit of work in this area where, the sort of theory says, well, the price responsiveness as a result of these things should decline, because the whole point of it is to try to lock people in, and you have these big jumps. And so if you have marginal policy changes in these experiments, then you shouldn't, once you've got the lock-in effect, you shouldn't expect much price responsiveness. But I thought, and it was striking to me how in both papers, in some cases it bared that out, even to the extent that the price responsiveness in some cases was zero, which was pretty striking to me. But I thought, I mean, one interesting question would be sort of to look at how that price responsiveness changes across different policy scenarios. So we adjust the Medicare levy surcharge. What happens then to people's sensitivity with respect to premiums? I didn't see that in it. Maybe it's in the results somewhere, but so we sort of had responsiveness of take up to MLS and responsiveness of take up to the rebate. But then what if I change, do one, what happens to the responsiveness of the other? And I think, and from a policy perspective, that's really interesting, because then you can say, well, if there's a lack of competition in the insurance space or more competition and demand is relatively inelastic as we change these policies, and if it gets less elastic, then that has implications, all sorts of implications for market power and all those sorts of things. So I thought that would that would be one of the things, if you could get a handle on that, that would be interesting to look at. But yeah, two great papers. It's really good.
No, thank you. So let's go 1 second. I think to Rosalie, we said, please, Rosalie.
Thanks, Francesco. I agree. Two really great presentations, and I really love the seeing kind of revealed preference and stated preference presentations on the same topic at the same time. It's kind of like what we it's really nice to look at both of them because they give us different pictures and different stories. I think they also had some interesting differences in results. So my takeaway from Nathan's presentation, I guess, is that consumers actually aren't particularly sensitive to either the MLS or the rebates, in many ways. So that sensitivity isn't there. Whereas I think in the stated preference, the second presentation, which I really liked, I think it did look as though there's more sensitivity. Now, I do wonder that sometimes it's like because you're actually asking people to focus on this, and so they're responding to the question that's in their mind, whereas that's not actually the way that they make their private health insurance decisions. So it is really tricky. I think this is an area where stated preference has a lot to offer, but there are some real challenges in trying to actually kind of mimic the choices that people would make. The other thing that stands out for me is, I guess, the complexity of the structure of private health insurance pricing in Australia, and therefore the complexity of the choices that consumers are making, because there's, the premium that you're paying each month, which is hefty. There's the impact on your tax, and the whole question of, and Stephen pointed to this, do you plan to use your private health insurance? Because that's going to make a big difference. So do you have any mind? And then there's clearly a bunch of people, and I think that did come out in both presentations, that there's this diversity across the, in terms of consumers, that some people have very strong attachment to private health insurance and belief that they should have it, whereas there are other people who are really, truly making a financial decision. And so those things about people's reasons will affect their sensitivity, and we actually can't necessarily see that in either set of data, which is one of the challenges. I think the other thing I just want to comment on, and it's already been said by a couple of people, is it always brings me back to the question about what is the objective here. I think a lot of these policies have come about because of this kind of strong received wisdom in the Australian system that if private health insurance drops, the system won't cope, and that there'll be this kind of, crisis because it will move people. But in fact, there's not necessarily a relationship between people having private health insurance and their use of private health insurance, or their decision to go to a private or a public hospital. That's much more driven by certain circumstances. And as Stephen said, things like, do you need a hip replacement? Do you need a knee replacement? Are you planning to have a baby? And so I think there's a question about, how much we spend on policies such as the rebate, particularly, to try and increase uptake in private health insurance, when we think about whether we could put that money into the public hospital system and how the impact that it could have in that way as well. So I might just stop there because I think there are other people who want to comment as well.
No, beautiful. No, I this is a very nice cue to go to Andrew, and I'll try to put a bit of the ingredients here together. Of course, subjectively. So forgive me if I don't haven't captured all of them, but. I think this objectives element that Florian raised, Alex and Rosalie echoed, is quite important and interesting, right? Because, and I would like to push this a little bit further. Like equally, what Rosalie said is very interesting, right? So what happens to private insurance may not really a sneeze in private insurance or a cough may not necessarily create a pneumonia to the healthcare system. Equally, the public health system is in crisis, as we see, and actually take-up went up. I mean, if you think about when we started this project, there was this concern of private insurance adverse selection spiral. You might remember the press, I think it was just before COVID. Well, now we have waiting times, pressures, scarcity of doctors. The public system is independently in crisis, and take-up has actually gone up. So, of course, there is this. So now, pushing a little bit, Andrew, the discussion, and thinking about these objectives, one might ask himself, and also looking at other systems, is there a relationship that we can establish about the tools that we currently utilize in private insurance and the objectives of the private insurance system, and with that, I mean also how those connect to the overall health system's objective. Well, what's your take, Henry, on that? That you've been thinking about these objectives when we started this for a very long time. What are we doing here? Please.
Yeah, look, first of all, thanks for the two papers, because one of our objectives is to get this debate out there in the open and have lots of conversations on it. So it's important. In terms of objectives, Florian, it was one of the Francesco's saying this because it was one of the first questions we asked the Department of Health when we started this work was, what's the objective here? And they summarised it quite well, I thought, in that their objective, and I'll repeat it here, it sounds pretty basic, but their objective was universal access, quality healthcare, best health outcomes for society, and an efficient cost to individuals and the community. There was nothing in those objectives around maximising private health insurance or anything like that. So there were sort of four levers, four parts of that is universal access, let's call it affordable access as well, quality healthcare, best health outcomes, and efficient cost to individuals and the community. So that's what we took as objectives. In interviewing stakeholders, three other things emerged that kind of are underlying some of the comments made here tonight. Was community rating was seen as not touchable. We can debate that, but there are a lot of participants and stakeholders that said we want to keep community rating. I don't think these are objectives so much as principles that they wanted to keep. So the first one was objectives. Then I think there are three principles, and they all start with C, believe it or not, community rating. The next one is clinical quality, whether it's in private or public. And Australia happens to have a mixed public and private delivery system. And the third one was unspoken, was that having some sort of competition in the system between private and public delivery, but also between private, not one, not just raise taxes to collect the money to fund the health system, that something around competition creates innovation. So those were the sort of three principles of community rating is important, clinical quality is important, and competition creates innovation.
Thank you. All right, fantastic. So I think we got to an important point. I would like to go to Yuting. She had her hand up. And patiently waited. So please, Yuting.
Oh, thank you. I just two things. One is responding to Alex's point about the different population respond rebate or levy surcharge. How do they differ? Nathan and I actually looked into that through that paper Nathan presented and something else. So basically, and a lot of other people also worked on that. So basic idea is it varies a lot. So if we look at general population, say 10% of price reduction in the private health insurance premium lead to about 3 to 5% of increase in terms of uptake of private health insurance. That's the general average on average. But for older population, we're talking about people older than 65. That's much, much smaller. So that lead to 1 to 2% uptake. So they're less responsive to price. And similarly, for high-income people, they're much less responsive compared to the poor population. So what we find through a different paper, basically the people in the first 25, the bottom 25% of earners, they are responding most in terms of rebates and some other financial incentives. So that's, to answer your question, it's a great question. That's something we actually know a little bit about already. And then Francesco did mention about if we think about this whole, a lot of policy introduced 23 years ago, the main justification for that, at least from the government perspective, is increasing, like more people buy private health insurance, they use private system, that might reduce the pressure off the public system. We actually recently have a recent paper looking at that particular topic, especially focused on waiting time in public system, public hospitals. We realized what we find was the effect is really, really small. So we're talking about, say, 1% of increase in terms of proportion of people buying private health insurance lead to maybe 0.3 days in waiting time in the public system. And that's out of, on average, 70 days of waiting time in the current public system. For that paper, we use Victoria data, linking inpatient and waiting time data for that one. But I think because of the financial system and the funding system model across Australia in different states, they're quite similar. So we think it's potentially could be generalizable to the whole country. So that's to answer your question early on.
Thank you. No, that was perfect. Of course, the waiting time aspect and the impact is one of the elements, because of course the government could simply say, okay, let's support this system to save in spending in the public sector, and then we'll do what they want with those resources. Like that could be, from a public finance perspective, a legitimate standpoint. So we have to consider a lot of different variables. And in fact, the offset paper that we spoke about in the previous seminar presented by Tom McGuire actually talks to that. So even in that, there is a lot of complementarity between what you think is doing, myself, Tom, and Joseph in that case are doing. And of course, there is a lot, and it would be amazing to have 5 hours to go through all and trying to make the connections. But I'd like to go to Steve and try to actually even try, and of course, Steve, you go where you want with it, but my idea would be, so if I'm hearing here, there is, of course, everybody more or less agrees that it's key to identify these objectives. I'll go after you to Florian to see what they are, for example, in Germany, and what the tools are in Germany to achieve those objectives. Now, I always wonder, given that there is so much uncertainty about the objectives, how are we so sure that these are the right tools? Or otherwise, do we know, or we think the objectives can be made a little bit more transparent? Because at the end of the day, there must be some objectives there to have these tools. It can't be both worlds, right? So I want to take your view on this, which is a puzzle for me at the moment.
Yeah, so I think in response to Yiting's comments there, I think using waiting lists as a non-cost rationing mechanism for healthcare is a catastrophe. And it has a massive human cost that I've never heard mentioned once by anybody in the discussion tonight. There's very strong evidence that waiting for care is bad for people. We have a mental health crisis at the moment, and there is strong evidence that waiting a long time for elective surgery in public hospitals is terrible for mental health. It often means that when patients eventually do have care, they're much worse. They've got high levels of comorbidity, and their original condition often is worse, which puts a lot of stress. It also means that they spend a lot of time in emergency departments, which are incredibly expensive places and are lethal, because we see ambulance ramping around the country at the moment, and a large proportion of people are people who are waiting to have elective surgery done for various things, who are seeking care in emergency departments. So we've got to widen it out from just thinking, oh, what a great, non-cost way of rationing care, because that does not take into account any of the other things. And I think if we look at the moment, 2/3 of all elective procedures in the country are done in private hospitals. Public hospitals are not coping anywhere in the country. We have 500,000 Australians waiting for elective procedures at the moment. Anything that's going to sort of take away, the option of people going to a private system, I think is a recipe for absolute disaster. There's no elasticity of supply of medical care in the public system at the moment. So I think we've got to be really, really careful how we frame this stuff and not look at it just from a technical efficiency or an allocative efficiency, but we've got to take into account all of the other things we're looking at.
Absolutely. That's a very good point. All right. I'm going to insist with my question about objectives and instruments, and I'm going to go to Florian with that.
Probably we are not better in achieving these objectives. But I would like to add something which is quite interesting. We have a similar problem, but in a different way created, of waiting lists. We have different waiting lists for people who are insured in the public system and in the private system. And in Germany, it's a bit different. We have about 10% of our 20% of our population has the right to choose between full health insurance coverage by private system. 10% of them choose the private system, and in the office-based system, family doctors, specialists, there's a different reimbursement system between private health insurance and public health insurance. And the private insurance pays in this completely different system more. It's up to double or three times for the same service. They pay 2 times or 3 times the amount. And there are quite some physicians who have different waiting lists for private patients and for public for the patients of the sickness fund. So it may be that you have to wait 6 weeks as a patient from the sickness fund and only 3 days as a patient from the private system. So this may create also really uncomfortable situations. I don't think that's what we want to see. We should have the same access to these systems, and we have problems created by a different system, but resulting in similar problems. So, but it's grown like this, and it's not so easy to fix it. It looks like, oh, you can do it like this and just get rid of these private health insurance, full health insurance. It doesn't work so easy. There were political tries to do that, and there are legal issues that are against that. So it's not easy, even if it looks like that.
Okay, very good. So now I'd like to maybe Manos, if you and then Nathan want to make some points, and then I'll go around with a very quick closing, because of course we're a little bit over time, just 1 minute at the moment, but we have been doing great. I want to note and remind that I asked both you and others to answer this question about tools and objectives. So when you think about the final comment, maybe help me out here. How do we reconcile this? Okay, so we do have tools. We may not know our objectives here in Australia. How is it in Germany? There must be an answer to these questions. Or we do have the objectives, we just are not articulating it in a clear enough way. You think made an attempt 25 years ago, these policies were introduced to reduce the pressure of the public system. Her research shown that in terms of waiting times, we're clearly not doing very well. And other research shows that maybe you can make some offset cost saving for the public system by using these policies. But how do you spend these extra resources? Really, if you spend them in any form or shape. So where are we with this dilemma? Are the objectives clear enough, or there are other than the ones that we know, or are the tools not adequate or not up to date, or even right? Perhaps is also another option. Okay, so now I let you reflect on this. I'll come with a very snapshot answer. Because I want to go to both our beautiful presenters, Manos first, and then Nathan for comments.
Okay, thank you, Francesco. So just quickly to touch on 2 points. So the first one was around lifetime healthcare coverage heterogeneity. Indeed, we do. I don't remember who made the comment. So, but indeed, we do see this sort of cutoff, if you like, on age. So, which plays along with what the policy is intended. I mean, we can explore it more and see whether essentially the two counterbalance, so basically whether the overall effect, if you like, cancels out because of the heterogeneity. I haven't looked at this specifically. The other one is, again, someone mentioned that what happens when we actually have simultaneous changes, and how does the change in a policy affect another policy, or the effect of another policy.
Alex.
So this is something that we can test. I don't remember. I think that we didn't find very much, and that's why we didn't explore it. But it could also be that it were just too many results, so we dropped. But this is something that we can for sure look at. Now, to go back to your point, I mean, yeah, nobody, it seems, that have an answer, so neither do I. But what I can say is that if we do identify, let's say, objectives, so if you look at it from the other side, if you have a tool bag, then what we can do is that we can test them all. So the type of, which is along with what Rosalie was saying before, that the type of experimental setups that we have allow for testing any sort of mechanism. So if you want to approach it from the tool side and see effectiveness, or from the other side, if we want an outcome or to achieve a specific outcome, we can at least conceivably set up an experiment or so to see what is the fastest or the most, let's say, efficient way to achieve that. So while I can't say what the actual answer is to the objectives or the tools that should be used, what I can say is that there is a way, if we know, to try and find out.
Very good. That's what we like to hear. Nathan.
Yeah, I mean, it's been a really interesting discussion. I don't have a lot to say at this point. What I find quite heartening is that the discussion certainly leaned towards what are the objectives of encouraging people to buy private health insurance. So that's come up over and over again, and I think that's something I've been thinking a lot more about as a researcher. So that's sort of work that I want to engage in. I think it's really interesting to look at the effect of the MLS, lifetime health cover, on take up, and take up's one of these things that's really easy to measure, but it's just not the ultimate objective. So I'm very so I think the recent work that UTing's doing is great, and I'm quite optimistic that there'll be more of that in the future as more kind of linked administrative data becomes available, particularly hospital data. So I think that's been a real constraint, but I think that constraint is weakening.
Very good, thank you. So I like to go with my obsession question to Rosalie first, to get her sense, and maybe add to that part, in a very sort of provocative but quick way. If you could do something to the system now, one thing, what would that be, Rosalie?
What a tough question to ask.
It's for everybody, so I mean, it's
so I guess I'm thinking about the points that Stephen raised about the pressure on the system and the impact on waiting times, and I absolutely agree with him that people waiting for elective surgery is a really major issue. Now, I don't have the solution to that, but I guess an injection of funds would make a difference to being able to reduce some of those waiting times. Now, where that injection of funds should be, I think, is the question that we're really looking at, sort of in terms of, is it best done via the private health insurance system or encouraging people to take up private health insurance? Or is it something that we should be actually looking at? How much funding should we have in public hospitals overall?
Thank you. Great answer. Alex.
Thanks. I just put up my hand because I've got to go to another meeting, but this has been a great discussion. I mean, I think what we're sort of talking about here is, what are the benefits and costs of different policy options, and go back to Florian's point about what's the objective. Well, from a productivity commission's perspective, it has to be the overall well-being of Australians. But funnily enough, trying to work out the costs and benefits of something can only really be done with a cost-benefit analysis. That's the so I think that's, you know, if you're trying to answer your question, Francesca, and I say this all the time, the only way you can work out costs and benefits is to do a cost-benefit analysis, and that would take into account all of the kinds of things that we're talking about. You would try to put dollar figures on all of the potential costs that Stephen was talking about, and you would account for changes in public finance, and you would go through all of these tools, noting the evidence that we have been presented with today, and you would do that analysis. Now, not having seen it or done it, I don't know what the answer would be, but that's what we have to do. Yeah.
That's very good. So we have so far we have a cost benefit, certainly integrated with more information from the experimental side of things, where we test the scenarios, is clearly complementary or informative of cost benefit, and then of course injection of funding, importantly to address conjunctural but also structural issues, clearly necessary as out-of-pocket spending is going up. I'd like to go to Steve.
Yeah, thanks very much. We've got a big natural experiment going on in the moment, which is the National Health Service in the UK, which is an utter catastrophe. So I think we can look into that crystal ball and say, if we drop the private health system in Australia, what's going to happen? Just look at the NHS. 7 million people in the UK waiting for elective care. All the doctors and nurses leaving. 25% of healthcare workers are looking to go somewhere else. So we've got a big natural experiment. I think before we tinker with anything and say, oh, let's drop this money from the private health system, as someone who works as a surgeon in the public system and the private system, I can tell you, you go down the NHS route, you are buggered.
Okay, wait, Steve. No, I want to hear if you could do one thing. What would that be?
Spend more money on prevention. Stop people
getting
the surgery.
Okay, funding. Okay, we have a very aligned in this little final experiment. Thank you, Alex, for leaving us and for being with us most of it. Thank you. I would like to go to you, Tim, with the same snapshot.
I probably would agree with Steve about preventing instead of trying to treat disease when it's too late. But if we just focus on private health insurance, I would recommend more targeting the policy. So that's two fronts. One is targeting the really poor who need the rebate. The other one is more targeting on the levy surcharge. I would be comfortable drop that policy, or at least increasing the threshold, but not requiring any higher compliance in terms of requiring minimal silver plan or something.
Fantastic. Andrew.
Mine would be simple, Francesca. I think things like this where people get connected is good. And overall, I think we've got to stop talking about there being a private system and a public system. There is a health system, and we want the best outcomes out of that system, and it's going to be a hybrid of the two. The normal general public don't care so much. They just want to get treated, and they want to achieve overall well-being of Australia, whether it's public or private. And in this meeting, sometimes we digress to just talking about private or just talking about public. It's both, and it's get the overall health system right. Or if I had to put it in 4 words, I'd say ITSS. It's the system, stupid.
All right, so, but you didn't answer what would you do unless the answer is more of these meetings.
I think the answer is to start thinking about it as improving the overall health system. We're not trying to increase participation in private health insurance, or they're all sub-objectives. The main objective the Australian population wants is a working health system and good well-being for all Australians.
Very good. Okay, so fantastic. Thank you so much. Florian? We didn't hear anything about risk adjustment, and it's your last chance.
No, actually not. It's difficult coming from another country. I do not know how it really works, the healthcare system in Australia. So my thing would be to bring more transparency in the system. And there's one special issue I would be interested in, coming from the insurance industry as well. When does private health insurance pay for services, and when has public insurance pay for services. And this decision has to be, it has to be clear who makes this decision. And that cannot be one time this person, the other time this person. There should be a clear regulation. If you don't do it, there are some individuals, providers, insurance people, individual insured, who make profit of this unclarity in the system. And I think at this issue, it makes sense to have a closer look and to have some data who is doing what at the moment.
Fantastic. So thank you, everybody. To conclude, I really want to thank the two speakers, all the panelists today. We clearly have had consensus that there is a very strong need for this type of research to be definitely coming out and more often, also to stimulate these types of discussions, which clearly bring benefit in the thinking about these problems, also their solutions, and also the learnings from other countries. We also heard the importance of finding ways to target the most vulnerable, which are clearly the low-income individuals. We didn't talk about it so much, but clearly the high-risk ones ultimately are the ones that really clearly directly are recipient and in need of healthcare services. So with that in mind, I really want to thank also all of you who came today and attended, and in particular Marcello, who's been with us all this time, who has been incredibly helpful and instrumental to make this event happening. Have a great evening. Thank you all for presenting and being part of our panel. Enjoy your night. Bye. Bye.